Well, hello, everybody. I am Dr. Ted Barnett, president and founder of Rochester Lifestyle Medicine Institute. It's so exciting to have people joining us tonight for our April Lifestyle Medicine Grand Rounds. And tonight we have a very interesting case presented by Dr. Kim Scheuer of Love.Life Telehealth and who lives in Colorado. Here's our agenda for tonight. We'll be doing some introductions and announcements for the next few minutes. And then at 7:35, we will start our presentation. The presentation will go to about 8:15, at which point we will encourage the audience to join us for Q&A. Please put your questions into the Q&A. And at 8:30 p.m., we will officially adjourn. And at some point after that, you will receive an email with a link to a survey. And if you fill out the survey, you will receive 1 hour of CME as a PDF in your email. We will then, after you've been officially dismissed, we will then move into the lobby, which we love to do because oftentimes the conversation gets even more interesting at that point, and it's a little less formal. We'd love it if you could would like to work with us. We run several great programs that help to empower your patients. We have online referral forms on our website, rochesterlifestylemedicine.org, and we have they are standardized programs that help to build motivation and competence for people anywhere in the country or, in fact, in the entire world. And these are the programs that we run. Our own 15-day whole food plant-based jumpstart, which is certified by the American College of Lifestyle Medicine. But we also run the LIFT project, which is also certified by ACLM and put out by Darren Morton in Australia. And then we run health coaching. All of these things can be learned. You can learn more about these things on our website. CME credits are available for a number of our programs. Again, also, you can learn about that on our website. In terms of privacy, please respect the privacy of the patient you will be hearing about. It will be pretty hard for you to figure out who that person is. So I'm not too concerned, but again, we want that person's privacy respected. Our case presenter tonight is Dr. Kim Scheuer. She's board certified in both family practice and lifestyle medicine. She started the online focused practice Docs Lifestyle Medicine and also practices with Love.Life Telehealth. She is licensed to see patients in 25 states. She's also conversant in Spanish and American Sign Language, which she uses to bring her knowledge to multiple communities. And in fact, Dr. Scheuer has actually been our medical facilitator for one of our Jumpstart programs that was run entirely for the deaf. Dr. Pritesh Mutha is board certified interventional gastroenterologist and associate professor at McGovern Medical School at UT Health in Houston, as well as being board certified in lifestyle medicine. He's also the director of the Third Space Endoscopy Program for the Center for Interventional Gastroenterology, IGUT, at the UT Health in Houston. In addition to his clinical experience, Dr. Mutha's peer-reviewed research work has been presented at national and international conferences and published in prestigious academic journals. In addition to specializing in many acute and chronic conditions and performing various endoscopic and colonoscopic procedures, he works closely with the oncology and surgery teams to help with the timely diagnosis, staging, and management of gastrointestinal tract cancers. And in the interest of time, I'm just going to post this so that people can look at this later on the video. But Dr. Robert Breakey is one of our regular panelists. Dr. Kerry Graff is one of our regular presenters and occasional panelist, and just joined us as the medical director for Rochester Lifestyle Medicine Institute. So welcome to both of you. And Dr. Susan Friedman is one of my partners in crime. She's also at the University of Rochester and is the director of the clinical studies at Rochester Lifestyle Medicine Institute. And then there's me. I founded Rochester Lifestyle Medicine back in 2015, and it's one of my favorite things to do. So with that, we're going to turn this over to Dr. Kim Scheuer. Dr. Scheuer, if you welcome aboard, and welcome to Dr. Mutha and Dr. Graff and Dr. Breakey.
As you mentioned, I'm Dr. Kim Scheuer, and we're going to present the case on lifestyle medicine, rectal carcinoma diagnosis. So first, I'm going to give you some information about rectal cancers. Colorectal cancer is the third most common cancer worldwide, counts for 10% of all cancer cases. It's the second leading cause of cancer-related deaths worldwide. And the risk factors all can be very modified with lifestyle choices and are associated with unhealthy ones, like a diet high in processed meats, low in fruits and vegetables, sedentary behavior, obesity, smoking, and excessive alcohol consumption. So rectal cancer screening usually, it changes, guidelines change regularly, but recently the most recent guidelines are screening at 45 to 75. That's younger than it used to be because of so much increased risk and so much more increased rectal cancers. It's screening for every 10 years for an average risk patient. And then from 76 to 85, selective testing based on individual factors such as overall health, life expectancy, and previous screening history. 85 and up, not recommended. And then the testing is either with fecal occult blood test or FIT, fecal immunochemical testing, which uses antibodies to check for blood in the stool every year, or the DNA FIT, the Cologuard, which is every 1 to 3 years, more 3 years. CT colonography every 5 years. That's the virtual CT, and FLEX-SIG every 5 years, or FLEX-SIG plus every 10 years with a FIT every year, and colonoscopy screening every 10 years. So that's just some basics. And this patient was very clear that he wanted to teach others about his experience so that people get care that they need. So BR was a 66-year-old male when he first came to see me in last March of 23, with literally a new diagnosis of rectal carcinoma that day. He had a large fungating lesion with ulceration in his rectum found on routine colonoscopy at his first colonoscopy ever. He had a path and labs pending, and like I said, that happened that day, but he was told he would need chemo, radiation, and surgery. His history had been of intermittent diarrhea, constipation for years. Nothing changed on that. Some BPH. He was obese with a BMI of 31. His past surgical history had been for thyroid issues with no issues since, and a vasectomy. He was on no meds. He had recently started B12, and all his allergies were no drug allergies, family history. Mother died of an unknown cancer, father of a AMI, brother with hypertension and high cholesterol, and the brother is a twin. And he's a teacher, lives with his wife and dog, no alcohol, no tobacco, rare gummy, every 6 months at the most. Exercise, really hadn't done anything until just recently when he had a HDL that was low. He's had no sleep issues, stress issues, really nothing until his health diagnosis. He's loved his work, loves his family, has a great social life. Finances just recently had been a little bit iffy, but that was not a big issue in his life. However, he definitely ate a very plant-based, standard American diet. His wife had seen me previously for weight loss, and he supported her on her whole food plant-based journey, but he had not bought in. So in general, this is a 66-year-old male who had 3+ risk factors. He was obese, he was sedentary, and he had the standard American diet. And then he had late preventative care or evaluation. So at this point, I would like to ask the general group, what would you tell him about treatment? Because he was very interested in lifestyle medicine. So would you postpone conventional medicine for 6 months while doing aggressive lifestyle changes? Tell him to postpone lifestyle changes till he's done with conventional medical therapy. Tell him to focus on the pillars of diet and exercise while pursuing conventional medical therapy, or tell him to follow all the pillars of lifestyle medicine while pursuing conventional medical therapy. And then I'll save the last question just for the group, the panel.
All right, if everybody could fill that out as quickly as possible. I think we'll ask our panelists to let's see. Well, Kim, you want to just review what people have said, and then we'll ask for Dr. Mutha's response?
So it looks like most people picked number 4, which is tell him to follow all of the pillars of lifestyle medicine while pursuing conventional medical therapy. A couple of people said postpone, and then a couple of people said focus on diet and exercise.
Right. All right. Well, thanks for that. Dr. Mutha, what's your reaction to this quiz or this survey poll?
I absolutely agree with the majority. Focusing on all the pillars of lifestyle medicine while pursuing conventional medical therapy is the right thing. Although somebody who has not done this all at once, making all the changes simultaneously sometimes can be a little bit hard. It can be overwhelming. So you have to really have a discussion with the patient, understand where they stand, how feasible it is. Sounds like he has multiple factors already covered. So it's easier to implement all six because it sounds like 2 or 3 factors are already covered. So you're really focusing on 2 or 3. There has to be a discussion, but definitely those 2 factors with 24% selected are the primary things that they need to focus on at this point in time. And definitely the other 4 will kind of, follow when you focus on these 2. And slowly, steadily, you can add those for sure.
Yeah. Dr. Graff, your thoughts, please.
Right now, this guy's motivated by fear. He made an appointment the day he got diagnosed. So you need to pay attention to that love and relationships pillar because you don't want him to fall off on this. It starts getting better from the chemo and everything else that he's doing. And then he kind of gives up on the lifestyle medicine stuff because he's not motivated to make change once the fear starts to lessen. But if you're looking at where the evidence is for for impacting cancer and outcomes, it's in diet and exercise primarily, right? So making sure that he's focusing, and I would have a frank discussion about focusing on what it is that you love and want to be around for as you're making these changes. Just it also gets his mind off of how scary this is for him. And then focusing on making those changes without adding a lot of stress to his life because he's already pretty darn stressed. I didn't know when you were doing this on the scale of how stressed out he was and before, and you said he'd gone to 4 out of 5 or a 4. Was it out of a 5 or was it out of a 10?
10 out of 10.
So that's
he's a
really
very-
surprising to me. It's like you just got diagnosed with this kind of nasty looking cancer and you're only at a 4 out of 10. Like most of normal people just walking around are 3 or 4 out of 10.
I think
right?
he was saying, I think he was saying he was 4 out of 10 just because of the cholesterol that had been higher recently. And then this stressed him to the max that day.
Okay. Well, that makes me feel better that like he's now at a 9 or a 10 because he should be at a 9 or a 10 or else he's just not human. So we just that was a little confusing to me. And I was also curious, is his brother an identical twin or identical twin? So it's kind of funny that his brother's got the hypertension and the high cholesterol and yet he doesn't. And obviously you got to worry now about the brother with the increased cancer risk too. So just some of the things that kind of hadn't popped up yet that I would kind of pull in there. But I would tell him that there's really good data on using lifestyle as interventions to help with the cancer treatment, although there'll be times during his treatment that you're going to have to jury rig them so that you can tolerate them while you're in the middle of the treatment. But to try to kind of keep to those as much as you can.
Yeah.
How overwhelmed was he when you first saw him that day? Was he pretty overwhelmed?
He had cried for quite a bit before he and his wife had cried for a bit before they talked to me, and they were very together. Well, he more than her when they talked to me, and he's a remarkably calm man considering.
It would be really hard to take in much more information on the day that you got diagnosed with a cancer like this. So I'm not sure how much of what you can give him on the day of can actually get in there. So I might have kind of turned around and done a really quick follow-up when he had a little bit more time to kind of process stuff.
Yeah, thank you for that, Dr. Graff. Dr. Breakey, your thoughts, please.
Well, I agree with my colleagues. Number 4 is that all are important. Again, clearly, just like lung cancer is largely related to smoking and what we put in our lungs, colon cancer is largely related to what we put in our mouth and the food. And I'm sure we'll come back around to that. But all 6 pillars are important. And as we've talked a lot about the stress one, and that commonly heavily influences the sleep pillar. People with this have sleepless nights. And of course, that upsets not only the circadian rhythms, hormone balance, increases inflammation, but also disrupts the microbiome. Your bacterial colonies need rest as well. And without that, the disruption there can more directly affect the colon through they do the job of reducing short-chain fatty acids, detoxifying many of the things we eat in our food. So indirectly, nutrition, sleep, both affect that component of things. And again, I'm sure we'll come back around to this, but good question. Clearly, we all agree. You don't give up on conventional therapy and you implement lifestyle medicine all in right away.
Excellent. Thank you for that. All right, back to you, Dr. Scheuer.
He was, when we talked that first night, he was very worried that he couldn't get into a specialist for several weeks. And he just was very frustrated with that. I think he had like 3 or 4 weeks before he could get into somebody, even though he lives in a fairly metropolitan place. So I suggested we start treating that very moment. And he was surprised that I said, we're treating you right away. And we talked about stopping feeding his cancer immediately, getting him to an ideal weight. I gave him multiple resources. He did very well with this. And he actually said in the end that the amount of information I gave him a chance to focus on healing rather than worrying about that. So he got books, he got all kinds of things. I suggested he start regular exercise immediately, given its role in preventing metastases, and I'll talk about that a little later. I emphasized the importance of sleep, stress reduction, avoiding toxins, social connection, all of which, as we noted, he was good at, but I wanted to reinforce the need to maximize these components of health throughout his treatment. We've talked about getting sunlight every day for infrared. We encouraged routine immunizations before treatment because it was coming on winter season, and I wanted to make sure when he was immunosuppressed, he might get that. We discussed what was most important to him was, and still is, quality of life. And that was an interesting discussion with him. And so I talked about the diet role in colorectal cancer, and he absorbed everything about the processed meats, red meats, and getting rid of that immediately. We talked about lifestyle interventions on diet, which are feasible in people with colorectal cancer and should be perioperative, preoperative, postoperative, and treatment to potentiate his health benefits. We focused on whole grains, vegetables, whole fruits, plant proteins, healthy fats, discussed to avoid high glycemic diets as the role of sugars in, high sugars in cancers, and told him to get rid of the refined carbohydrates, especially sugar sweetened beverages. We talked about exercise role, and I sent him, his wife liked to get as much information as possible. So everything I found on it, including the systemic review that talked about lifestyle interventions, include, how exercise helps in all stages of cancer to help with health benefits. I sent him something on exercise-induced metabolic shield, which is exercise-inducing metabolic reprogramming of internal organs to increase nutritional demand and protects against metastatic colonization by limiting nutrients available to the tumor cells. And we talked about aerobic strengthening and trying to do that throughout every stage, because we talked about how difficult this might be. I gave him tons of books: Stop Feeding Your Cancer, Radical Remission, Life Over Cancer, Dr. Greger's books. We went through all kinds of things, from the technical to the spiritual. We talked about the NCCN National Comprehensive Cancer Network guidelines for patients. And I provided him with that. It's a great resource for all kinds of cancers. And it even has questions to ask your oncologist. So we talked about if he was going to do surgery, making sure they worked on an ERAS protocol for colon cancer. This happened a little bit later, but eventually I did talk to him about the Block Center. Dr. Clapper, one of my colleagues at the time, and everybody knows the esteemed Dr. Clapper, had mentioned that Dr. Keith Block, who actually wrote one of the books I had suggested, plant-based physician with compassion and a healing spirit, who was an oncologist who works with both traditional and also lifestyle medicine, because he was concerned about a second opinion. We talked about Signatera testing and testing afterwards. We talked about, we want to be as plant-based as possible. And if he wasn't tolerating foods, Kate Farms is a option that instead of Ensure, if needed during treatment. So we went through a lot of things pretty quickly. And this is just the NCCN guidelines for patients. It's got great information for providers too, way above my head, but it's very comprehensive, extremely comprehensive. And so very helpful for patients. The ARIS protocol, we'll talk a little bit more about that, but how to optimize surgery and healing. I did do a very quick, we were in contact fairly regularly, but within 10 days, I saw him again, and he completely changed his diet the day we spoke. And it was helpful that his wife was already whole food plant-based. He concentrated on G-bombs tea. So G-bombs are greens, beans, onions, mushrooms, berries, and tomatoes, seeds and tomatoes from Dr. Furman, because they all have cancer fighting properties. He started exercising daily. In 10 days, he had lost 10 pounds. He was now no longer in the obese range. This is a very tall guy and big guy. He was focusing very hard on positive attitude with gratitude. He reached out to his family, friends, and community, and he said that has kept him going through this whole last year. He did extensive research on the materials I gave him, and he really appreciated them. And we got back by then the path, which was, he had a mass 10 centimeters from the anal verge, and it was a T3CN+, which means it spread to the inner lining of the bowel wall, but not through, and possibly to lymph nodes, but not distant. There was one lymph node that was very suspicious, located at L5S1, and that was very concerning to all of us. His labs were shown there, fairly good. His path, the final diagnosis was invasive adenocarcinoma, moderately differentiated, and he was recommended to start 5-FU with radiation treatment for 6 weeks. So a milder chemo with radiation, then Folfox for 4 months, then surgery. And so he was not excited about all of this, but we had discussions about whether this would help him or not. And I basically said that I wouldn't feel comfortable just doing lifestyle medicine for this. I wouldn't have the guts to just stay with lifestyle medicine, but I would do both. We talked about preparation for chemo and radiation because he was leaning that way, and that fasting mimicking diets or fasting, there's some good studies on that. And through all of the research and things, he decided to go 1 to 2 days before chemo fasting, then continue 1 to 2 days after starting chemo. Because what fasting does is it tends to shut down the normal cells, but the cancer cells keep going. And so if the normal cells shut down, they don't gets as much effect from the chemo, and so you have less side effects from some of the research that I had seen. And he actually reluctantly at this point agreed to have preliminary chemo and radiation, even though between his CT and the long wait to see the oncologist and everything, he ended up having an MRI. And the CT originally showed a 3.7 centimeter tumor. And then 10 days later, he had on an MRI, now obviously different study, a 3.1 centimeter tumor. And, but he did agree to start chemo and radiation. He completed that 6 weeks. He originally did well, but after several weeks, it got really tough on him. He was told by the original team to start chemo immediately after finishing his original treatment. And again, he was not sure. They didn't buy into the lifestyle medicine parts of this. they didn't prevent them from doing it, but they weren't on board with it. And he wanted to put off further chemo because he felt like he was hurting himself. He also wanted imaging again to see if there was a difference because he was second guessing. Should I even started this? They refused to re-image him after his original chemo and wanted him to do immediate aggressive chemo. He changed to a new oncology team who did agree to give him a little bit of break before the aggressive chemo and to imaging. And his follow-up imaging showed significant response to treatment with no evidence of residual viable neoplastic tissue at the site of previously identified tumor. Unchanged original suspicious lymph node, which because it was unchanged now was suggested not neoplastic, which was wonderful. And he declined to go ahead with aggressive chemo at that point. So what would you guys do? Would you tell him to postpone conventional medicine while continuing aggressive lifestyle changes? Tell him to continue lifestyle changes while continuing with conventional medical therapy, or suggest other options? And remember, he was supposed to go straight into FOLFOX for 4 months and then surgery.
All right, so if people could think about this and give us your reactions, please. So just as a reminder, he hasn't had surgery yet, right?
No, they were very clear. They wanted him to do low dose chemo radiation for 6 weeks, then very intense chemo, and then surgery. That was the protocol. And both the teams had agreed to that, had suggested that was the way to go.
All right.
Very interesting. So,
Yeah. Dr. Mutha, what do you, yeah, go ahead. Let's have Dr. Mutha comment on this. You can see it.
Yeah,
So
absolutely.
Yeah, no, I would definitely recommend what majority of the people recommended, 62%, that continue with conventional medical therapy while getting lifestyle changes. The fact that we have to understand is this cancer did not happen overnight. It's been brewing there for years before we saw it. So he was worried that he didn't see a specialist for a few weeks. Few weeks is like a couple of hours in terms of cancer, time span. The other thing we have to understand is there is something called as synchronous lesions and metachronous lesions. That means if you have had lesion at one place, there's a good chance there was lesion somewhere else, or it is at equal risk. So that's why we do a full colonoscopy and we repeat in 6 months to make sure that there's no other, and then a year after, to make sure there's no other area where there is newer lesions that has grown. Now, we also do newer blood tests, signature blood tests you talked about, which looks at the circulating DNA molecule tumor. So these cells are circulating in your body already. When you do localized treatments, it does not necessarily get rid of all the cells that are circulating around. Lifestyle medicine is excellent, but you've done damage for decades of your life. You can't, take care of it within a matter of few days to weeks. And many times you think you're doing everything right. And when you really go into details, you realize lots of things are sneaking in which they didn't even think were bad for them. So definitely, given all those factors, I would recommend continuing conventional medical therapy, but pursue lifestyle changes aggressively and go back and look at it and make sure you're not missing out on anything and keep working at it. Definitely, I would like to add that fasting component was excellent. More fasting, the better. And everybody's concerned, mainly the oncologists themselves are concerned that if they're fasting, they're not getting enough protein, no calories, and they're like, oh, they can eat whatever they want with just more calories. And so they get all these confused messages, and that kind of, confuses them even more. And it's a challenge. I don't have a good solution. I haven't found a good solution to that problem. Maybe you have. But those are the things that are coming in their way, and which kind of stresses the importance that they should definitely continue conventional medical therapy while pursuing aggressive lifestyle changes. Another thing I wanted to add was, there was a mention about red meat and processed meat. So this is a myth, I believe, because I've seen so many patients who have never touched red meat, forget any meat, and still they have developed cancer, colon cancer. And I'm seeing younger and younger patients. The push was to start screening at age of 40, but we just don't have enough doctors to start doing that. That's why the compromise came at 45. So I'm seeing plenty of young patients who've never touched any kind of meat and still have. So any animal protein And any even plant-based fat, high-fat diet, both are equal risk factors. And there's a whole mechanism, I can go over it. I know we have time constraint. But the point is, high-fat diet and any animal protein, both are equal risk factors for cancer cell growth. So do not be under the impression that it's just the red meat.
Excellent. Thank you for that. Dr. Breakey. Oh, go ahead. Well, Dr. Kerry's already unmuted, so Dr. Graff.
You know, I'm one of the one who put 3 just because I didn't like the tell him part, because he's already really resistant to doing anything, and I think telling him anything is gonna be would make it hard to get him on board with what I really want him to do, which is to going ahead with the chemo and continuing with the lifestyle medicine stuff. So to try to disarm him, like, well, you could do what you want to do. However, it's really likely that there's residual cancer cells in there. And you may be, missing this window of opportunity to whack-a-mole this thing when it's in the small stages, and you may miss out on your chance for a cure here. And
Right.
then let him decide what he wants to do based on that. Once you kind of given him your argument, lots of people kind of think, oh, I'll just wait till I see any recurrence and then I'll do it if I need to. But you don't recognize that you are adding this whole increased layer of risk that you didn't have to, and potentially missing a window for a cure. And I would want him to hear those words before he decided what he wanted to do.
So you were objecting to the words "tell him."
Right. I would, because I think that he would just get resistant, and I would really want to just offer that this is all, what I would recommend is that to do this, and this is why, and let him then choose which he wants from that, and have it be a soft sell, because I think he's just going to get resistant if you try to do a hard sell here.
Got it. All right. Thank you for that. Dr. Breakey, you're on.
Yes, I see your point, Dr. Graff. You don't want to be appearing to kind of push, or you may get more resistance. But I think we're all agreeing, or at least within our group here, that both are still important. The full court press on lifestyle medicine, but don't give up on conventional. There's that temptation to say, wow, I've made progress. It appears to be shrinking and I'm feeling better. And a lot of that just happens with plant-based diet. And then you get over confident. But remember, a 3-centimeter tumor represents billions of cancer cells growing exponentially. And with evidence for some spread already to a lymph node, it's likely that some thousands of those, which is a tiny percent, may have already spread further down that cascade or even into the bloodstream. So you have to be, again, extra cautious. In addition, many lifestyle metrics have been shown to kind of arrest the growth or slow the growth, but it's harder to get apoptosis to decrease it and actually wipe those out. So we can't yet give up on conventional therapy, but we do understand his confidence that lifestyle is meaning. And we want to encourage that. Say, yeah, great job. We're glad you're feeling better. We're showing some signs of progress. Keep with it because you're not out of the woods yet. One other thing to clarify, I agree with Dr. Mutha that red and processed meats you can't see those as the only, but I don't think he was saying that it's a myth that they increase the risk. It's them and all animal protein. And I definitely agree with that. Red and processed meats that tend to be the worst, but people who just say, oh, I'll just switch to fish and chicken, then don't recognize that animal protein, the toxins, the increased inflammation, the lack of fiber, and most importantly, stimulation of IGF-1 occurs from dairy, eggs, meat, fish, all of them. And these are all cancer promoters.
Dr. Graff, you have your hand up. Did you want to?
I wanted to add something, which is the other thing that I probably would have told him was that, you can always try the FOLFOX. The reason why he didn't want to go ahead with it wasn't just because the cancer had gotten better, but he had a bad experience with his last chemo, right? So he was really nervous about how bad it would be because he was told, the first chemo was the light chemo. This one was going to be the bad chemo, right? So he's like going into this thinking it's going to be so much worse than the first round. And then you could always say, look, it might not be as bad as you think. And if it does get really bad, then 2 months of FOLFOX is better than no months of FOLFOX in terms of your cancer treatment for preventing, for treating this. So just trying to be a little bit flexible with that, trying to pulled him on board to kind of trying to get this, treat this as aggressively as possible for the best chance for survival.
Yeah.
All right, thank you for that. And Dr. Scheuer, I know you have a lot more to tell us. So
Okay.
you have a lot more to suggest to us.
So we discussed, he and I discussed, I was very nervous about him not moving forward. And he didn't want to poison himself. It wasn't the side effects that he was so worried about. He didn't want to poison his body and cause more damage. And he felt that that would take down his own immune system to fight this. But we discussed, okay, if you are not going to move ahead, we have a couple of things I really want you to do. Please get a second opinion by the Block Center, which he did agree to do. And I also discussed, at the minimum, checking a follow-up sigmoidoscopy and Signatera test so that he could make sure that he was not progressing. And so he did agree to the Block Center, which made me feel a whole lot better, because that would be helpful. He ended up with a sigmoid biopsy and Signatera, which are both positive. And then he second guessed his original chemo and radiation, thinking maybe that was the cause of this. So, because again, another CT showed no measurable tumor on study, but luckily he went through with the second opinion. And when he went to the Block Center, they were like, you have to do this. Even though we're going to do all these lifestyle things for you and make sure that you do the lifestyle, you have, I think they said, a 500% increased risk of metastatic cancer if you do not go forward with this. And so this was a traditional medical facility that made me feel better. And it was he met Dr. Block and spent an inordinate amount of time with him and loved his philosophy about lifestyle and everything, and made him feel better about moving ahead. So he did, in 5 minutes, change his mind and go forward with the FOLFOX. It was tough, really tough on him. He struggled to get through chemo. He used THC cookies. They were whole food plant-based, but he did use THC cookies to get him to have any kind of appetite. He fell off the exercise and the eating at the end because he was just barely surviving. He had severe neurologic changes. He couldn't walk without falling. He couldn't, he was tied to a bathroom. It was very, very difficult on him and his family. He finished mid-December, and then he was going to go to another facility to find out about bowel sparing surgery. And as he was going, he was going to get a sigmoidoscopy at this new place to see about bowel sparing surgery. And they saw actually significant growth of the tumor at the site. And they decided that, okay, we're not waiting, because he thought he would go get a consult and then come back and then go again, several months later to get the surgery, because it was so close to his chemo. And they're like, nope, you're going in the next couple of days. So he had been fully whole food plant-based. He was starting to get his energy back. He was starting to move. He was starting to eat healthier again, and not healthier. He was eating healthy the whole time, but just eat. But then they switched him to a fiber-free diet for surgery, and nothing. They were very strict about it. And he wanted me to mention to you guys that actually, so he did the low fiber diet that they wanted right before his surgery and through the surgery. And then he had to go back to detox from processed vegan foods, because he was on processed vegan foods because that's all they would allow him to eat. And he said that was really kind of tough on him before he was allowed to reintroduce beans and fiber and nuts and seeds and all the other things. But so I just mentioned that here. It's kind of out of place. But we talked about the ARIS protocol for surgery, and he did talk to his surgical team about that, and they were very much on board. I warned him that the food in the hospitals are totally unhealthy. And so, if he was allowed to bring in foods for him to do that. And I suggested he get a plant-based knowledgeable nutritionist at the hospital, and just say he was ethical vegan, which he was by that time. He was truly ethically vegan, and he actually managed to get a plant-based knowledgeable nutritionist to help him for surgery and afterwards. I want more time to talk, but you can go to the ARIS protocol about what to do before surgery. Basically, it's carb loading with healthy carbs. And then, and to continue to eat up to 6 hours prior to surgery with clear fluids, including a carb drink 2 hours prior. And then after surgery, you want to focus on some higher protein foods. And I gave them some information on that, but this is all in the ARIS protocol. And so then follow up. He had the surgery and he was very concerned about that because he was told he would lose weight, and he had gone down to, his ideal weight was probably about 145, 150. He'd gone down to 126 before surgery just because he couldn't eat. But he sailed through it. All of his doctors were worried. He sailed through it. And within hours after surgery, he felt phenomenal. He had color again. He didn't look ashen and gray. He was able to gain healthy weight very quickly. He was able to walk 20 minutes without assistance 3 times a day within a week of the surgery. It was miraculous. And he felt great. He was no longer chained to the bathroom. He was one of those few that were like, I'm so happy to have my ostomy bag. His margins were clear. The CT was negative for Mets, and all lymph nodes were negative except one. And he was told he would not need cleanup after chemo because they had removed the one node. And he just felt fabulous. And he had planned to stay on his positive lifestyle changes forever. So I wanted to mention briefly an integrative approach that the Block Center uses. They use conventional treatment. They use the lifestyle medicine 6 pillars. They use what they call biology, they use a bunch of IVs to deal with oxidative stress, immune dysregulation, all of coagulopathy, stress chemistries, et cetera. All of it is evidence-based. They address treatments for toxicity, circadian disruptions within treatment, and relaxation techniques. They consider survivorship and continuing lifestyle changes after treatment. So this really fit with who he was, and it was a great place for him to go and a great place for me to feel he was getting good care. They emphasize life after treatment, health promoting, again, all of the lifestyle changes to make sure that he had a good prognosis, survival, quality of life. And I wanted to have a panel kind of address what they felt about really no cleanup chemo with lymph node ×1. I wanted to discuss active surveillance. If you guys had anything, physical expectations on his changes, psychological. He and I talked about scan phobia and psychological things. We talked about lifestyle medicine in the long term. And we had worked a lot with the partner challenges he had because his wife, this is not one person going through this, it's wife and family. And so we talked about this, but I just wanted to see if anybody had any comments about any of these topics.
Dr. Mutha, your thoughts, please.
So, thinking back, despite the aggressive chemo, he had worsening of tumor. So, and in the process, he actually fell off the wagon or had to go off the recommended pillars. It makes me question our initial thought process that should we have actually recommended conventional therapy? Now, of course, retrospective vision 2020, but alternatively, just thinking out of the box, there was a potential that he could have aggressively continued lifestyle modification, a lot more fasting without worrying about chemo, and that actually helps apoptosis. Having tons of fibrous loaded, which kind of gives butyric acid, which is again assisting in apoptosis and trapping all the bile acids, secondary bile acids, which are cancer promoting. So all in all, now I'm kind of shifting towards that with retrospective, that potentially there was, if you would have chosen only that, may not have been completely wrong, as long as it clearly has this idea that there's a chance that it can go sideways. But if you have that motivation, that clear goal and willingness, and that it's not completely off the table. Now, active surveillance wise, definitely surveillance is something that we strongly recommend because, as I said, synchronous and metachronous cancers. definitely 1 year later, you want to do colonoscopy and keep doing it for 3 years, 5 years, and so on and so forth, based on what you find. For sure, very important. And all the other, when you have cancer, the only way to surveil is doing a colonoscopy and none of the other tests. So doing a full colonoscopy with proper good prep is the key for proper surveillance. Otherwise, some patients, even with polyps, end up doing other tests for surveillance, which is not right. If you have had polyps or have had cancer, then definitely need to do surveillance with colonoscopy, or we can miss the initial lesions that we can easily remove before they turn into something of concern. So those definitely continue with the other factors, psychological expectations, surveillance, again, talking about that part. Yeah, those are my thoughts on surveillance versus and chemo part.
Thank you.
Interesting. So possibly those people at the very beginning who said they would postpone conventional therapy had the right answer, is what you're suggesting. Of course, we'll never know. It's a counterfactual, right? Dr. Breakey, your thoughts, please.
Yeah, it's like you say, it's one of those we'll never know. You have to make your best estimate with the information at hand, and we always assume that chemotherapy is going to be better than not chemotherapy. But there are risks, just like any treatment. There are risks to that, and it's toxic. It's rather indiscriminate, and that's why we hope that we can develop better kind of smart bomb approach to cancers. And indeed, that's a lot of what lifestyle medicine does by targeting the root cause, the angiogenesis, the tumor genes. In Dean Ornish's study of the biopsy-proven prostate cancer patients, he found over 500 genes changed just by his program of course 4 lifestyle metrics: nutrition, exercise, stress management, and connectedness. And those genes that were cancer promoters were downregulated. Those that were cancer fighters were upregulated. So we know that epigenetics can play a role, the microbiome, all these things make a huge difference. Clearly, we do need to have active surveillance. You want to encourage him to not be so afraid of scans. Those have a small risk, too, of inducing cancer because it's ionizing radiation. But it's on the order of 1 in 2,000. I know there's so many different parameters for this, and the data to extrapolate to that is hard. Maybe Dr. Mutha knows more about, or Ted knows more about that. But the risks are small compared to finding something that you might be able to do something about at an important stage. And I wonder if you had a PET scan, just by labeling the glucose, you could sometimes see the differential uptake within cancer cells, and that might help inform us too about how far or what next we might need to do. But definitely number 5, lifestyle challenges for the long term, and making sure that he stays on track, if only to enjoy the vitality that he found from that just by making the switch.
Great, thank you for that, Dr. Breakey. Dr. Graff, can you quickly?
Yeah, I don't have much to add to what's already been said, except that, there are 2 tools they did not give us in med school. And one was the magic wand, which would be really great. We could just make everybody well. And the second was the crystal ball, right? So anytime you're making, decisions about treatments, you're just going on, what are the odds here? What's your best, your best estimate of what's going to happen if you choose any of those routes. But boy, I can't tell you how many times I wish I had both of those tools with patients. And the other thing I wanted to add was on partner challenges. Thank God this guy had a wife who was already on board with whole food plant-based lifestyle, because that was just a save. It just saved everything. She could just take charge of all the food, where he didn't have to do that while he's working on his other stuff. And I don't know if that's really what happened, but it could have happened, right? You had that as the option of what could happen, which really takes that whole adopting a whole food plant-based diet the stress of doing that when you don't know what the heck you're doing off the table, because she knew what to do with that. So, and then I just like to put a plug in for blenderizing stuff and pureed soups, because pretty much people will tolerate stuff when it's blenderized, or when you know, if you make a butternut squash soup, even when your gut is not happy, you can tolerate that kind of stuff. So think about kind of liquefying it so the gut has less work to do when you're working through stuff like this.
That's
And we
great. Thank
did.
you.
And so one of the things, the scan phobia was more of keeping stress down when he's worried about what's the results of the next scan. That was more what I meant by scan phobia. But and interestingly enough, I mean, the Block Center, the Dr. Block, who wrote the book, originally in his book had said lifestyle first and only, and then changed after more experience. So his experience had said, you know, you should move forward. So it was kind of an interesting, you know, you always second guess. Should he have gone forward? Should he have not? So I have some more information, unless anybody else has any comments.
Just one comment here that, you know, if patients insistent on something, we are trying to steer him towards a chemotherapy, but if they are really insistent on it and they want to do it, we should support them through it. And I mean, knowing clearly that despite taking that, they may still go sideways. And even if on lifestyle medicine, they can, I mean, of course, odds are higher. You have a discussion. If they choose to do so, definitely support them that there is a chance that they can just do that and continue, because they would get to be on all the 6 pillars all the time and able to suppress all the 500 genes that Dr. Breakey talked about.
Yeah, interesting. Thank you for that. Dr. Scheuer, proceed,
Okay.
please.
So unfortunately, after his surgery and recovery, his Signatera came back high and it went up significantly from December to March after his surgery. His oncologist actually thought that this was likely from the surgery. They called the Signatera company. They said, yes, this can do it. They plan to recheck him in April. I sent him a message, you know, asking him to continue all the lifestyle medicine pillars to jumpstart his immune system back into gear so he could fight this. He asked, would a PET scan be appropriate? And he did talk to his oncologist about it. He had asked for a PET scan really early on, and the other team had said no. So he wasn't sure if a PET scan would be appropriate, what to do if his numbers went up, what other options he would have. In fact, his response when the Signatera came back was, I plan on living my best life for however long I'm given. Every day I spend worrying I don't absolutely need to, then I will not be truly living. And that's the kind of guy he is. You know, he's just very positive and a good person. And unfortunately, a half an hour ago, I got a message from him and his wife that he was supposed to get a Signatera test again on Monday, I think it is. He got a CAT scan today and he's got liver mets. And so I talked to him literally just before this. He has not yet talked to his oncologist. His oncologist said that she had 100% cure rate. And he didn't believe that. Originally, the family had said, you know, are you serious? And then when he came back with the aggressive tumor, she said, I've never seen this before in any of my patients, so that's why I think the Signatera may be not accurate, and let's recheck it. So I'm curious to see what his oncologist says. But at this time, he has, according to what they read to me, lungs and everything else was clear, but he has multiple new hypodense liver masses, lobulated mass in dome of 4.6 by 3.7 centimeters, and a right lobe segment mass 2.7 by 2.9 centimeters. So they're telling family right now, they're crying as they try and figure out things. They'll hear more tomorrow, hopefully. But I don't know if you guys have anything to help me help him.
At least now we know the full Fox was appropriate. So we're not really second guessing that decision anymore, whether he would have been better, right? Because his tumors are now progressing with despite having been on the lifestyle medicine protocols. You know, I'm not an oncologist, so I don't really have any kind of input to put on what to do next related to that.
Dr.
I
Mutha.
was actually doing some research back in 2007 on exactly this case, colorectal cancer with liver mets. And there are multiple treatment options available. Of course, some of these are resectable, but you mentioned multiple hypodensities. So I don't know how their localization is. That's definitely an option which surgeon can definitely tell us on. Additionally, there are certain options such as yttrium-90 therapy versus TACE, transarterial chemoembolization. So there are certain options, depends on, unless it is diffused, the liver is chock-a-block full of smaller metastases, and these two were big ones that he talked to you about. Then that's a whole different ballgame versus there are certain localized. So there are some options, and still there is good survival if we can get those out surgically and or, I mean, if surgically, that definitely improves the chance. So I mean, of course, this was my research 15 years ago. And since then, I'm pretty sure there are multiple other. I don't get, at this point in time, GIs are not involved because it is metastatized. So at that point, I mean, currently don't know what all the options are, but for sure, at least two of them are TACE, yttrium-90, and resection being the big one, if that would be the best one, if he's still a candidate for that.
Dr. Mutha, could you please explain the TACE and the yttrium therapy for people in the audience who?
For sure. Yeah. So transarterial chemoembolization is something where what they do is in liver, you have two blood supplies. One is portal venous blood supply, and there is hepatic artery blood supply. Tumor selectively is supplied by hepatic artery and not so much by portal vein. So they use this knowledge to treat the tumor. So by making sure that you go in, you do chemoembolization, so it pass the chemotherapeutic particles through that artery so that they are diffused into the liver and selectively attack the tumor and spare the liver, relatively spare the liver. And so you get the cancer killing effect by doing tumor TACE or transarterial chemoembolization. Now, yttrium-90 is another, these are microspheres which emit radiation, and they're also injected in similar fashion into hepatic arteries in the same knowledge. So those are the two options that are available. There are two types of yttrium-90. There are spheres and SIR spheres. SIR spheres are more diffuse, which are used for metastases like this. TheraSphere is something you use for hepatocellular carcinoma because they're more localized. So those are the two options, and resection, of course, surgical resection. That's the third.
Great. Thank you for that. Well, we're at an awkward period here because it's now 8:31. So what I'm going to do is I'm going to officially dismiss people, and then we're going to go into the lobby because this conversation is obviously going to continue a little bit longer. So I'm going to, Dr. Scheuer, if you could just stop sharing for a minute. I'd like to thank everybody for attending. You will receive an email sometime this evening, probably, with a link to a survey. If you fill out the survey, you will be rewarded with a PDF worth 1 CME. And if you do that all year, you'll get about 12 CMEs. So it's actually fun to come to these, and it can be rewarding. Also, we are a nonprofit organization. We're dependent on donations. So if you want to aim your phone at that QR code and send us a donation, or you can just go to rochesterlifestylemedicine.org and you can make a donation there, or you can go to Pale Blue Dot Community, which is also set up for this. So I'm going to thank the audience for attending, and thank Dr. Mutha and Dr. Breakey and Dr. Graff and Dr. Scheuer for an incredibly valuable and important conversation. And then I'm going to make you stay, okay? So, so great, yeah. So with that, Dr. Mutha, you just give us your thoughts. Dr. Breakey, what are your thoughts at this point?
2 points. One is that part of what we're dealing with here is what I refer to as the backlog effect. And the common effect is that people have stored up over the years on the standard American diet, saturated and other fats in their system. And along with that, toxins. Our body tends to sequester toxins in the adipose tissue. And remember that 10 pounds he lost is 35,000 calories worth of animal fat. That is his own. And it's made of the animal fat he was eating over the prior 65 years. So we think that, wow, he made these lifestyle changes. He should be able to arrest this cancer, get better, do everything great. Why is he still getting cancer? Well, a part of that effect, and again, I see it a lot in people with cholesterol. They say, I'm on a plant-based diet now for 6 months. Why hasn't my cholesterol dropped? Now, Jumpstart has a unique way of making this happen for sure, but other times we see a lag in markers because of that release of animal fat and toxins that comes out as people lose weight. It's good, they're getting rid of it, but it still has, as Dr. Mutha mentioned at the beginning, animal fat in particular is one of the most highly correlated with colon cancers. The other thing I just want to comment on is during his surgery, they're recommending he eat 1.5 to 2 grams of protein per kilogram. And this is excessive. We all know that for example, in our fastest growth rate as our first year in life, we triple our birth weight, and breast milk is only 6% protein. For sure, if he does want to try to meet that 1.5 grams, 0% of it should be animal protein, as we mentioned. And even that is more than is necessary. Every day, our body recycles 100 grams of protein. And this literature that shows, wow, look at these post-surgical patients, they're wasting muscle mass. They're needing to thrive. They're not healing. That's more related to the fact that they're inactive. You put a young, healthy person at bed rest for 4 days, and they lose a lot of muscle mass too. But they blame it on, oh, you're not getting enough dietary protein. So the answer is yes, you need more protein during that time, just like athletes need more protein. You also need calories, but you don't need to be excessive about these proteins, because all that emphasis on, well, okay, I'm going to make plant-based protein, pea and other protein supplements, or some people even worse, whey protein, animal proteins, which stimulate IGF-1. All that excess has got to come from somewhere. And what you really need is good quality phytonutrients, fiber, and energy. So isolated nutrients in the macronutrient form, whether they be carbs, fat, or protein in the form of oil, sugar, or isolated protein, are largely counterproductive. Again, good quality food sources of protein like tofu, tempeh, hummus, chickpeas, beans, whole grains. I'm all for it. But I just want to comment on that we, and I refer people to Dr. Garth Davis's book, Proteinaholic, as a bariatric surgeon down there in Texas, right? He's another Texan doctor. So those are my two kind of thoughts, observations. But most of all, Dr. Scheuer, he's lucky to have you as his doctor, because to be able to have a doc who will take this kind of bull by the horns, support his desire for, hey, I'm willing to do whatever I want. And, a lot of people don't. They're like, hey, just, cure me. I don't want anything to do with this. But anybody who's willing should be given the full court press. And unfortunately, most, none of us were trained in medical school, but most doctors just go, well, I don't know, just eat a good diet and go talk to your oncologist. And we need to integrate these approaches. It's not either or, it's an integrated approach with an emphasis on lifestyle medicine that gives us the best potential for outcomes.
I want to second that. It was a great case, but mostly Kim, you did an amazing job as his doctor treating this patient. So he is indeed very lucky to have you.
Hey, if there's anybody in the audience who wants to go live and direct a question to this august panel, this is your chance. Or if you want to put something in the chat or comments or questions.
There were some comments or questions in the chat, and I wanted to first thank everybody who talked about knowing people who've gotten through this, even with liver mets, because I will bring that back to him, and that makes me feel better and will help him feel better.
I have a question for Dr. Mutha.
Yes.
This is your chance to not use chemotherapy like you had. This is our second chance, right? What do you think?
Right, second chance. Well, but I don't know. At this point, probably I would recommend, if possible, if he's a surgical candidate, I would definitely, I mean, depends on the location of these lesions. That's something I would recommend. It will debulk, get rid of a huge load of cancer cells. And that's something definitely I would recommend. But during the process, they should not do what they did during his last surgery. I mean, getting him off of all the fiber, putting him in all the junk food, and giving him less of a chance to keep fighting through lifestyle medicine pillars and just relying completely on that surgical option. As long as they don't do that, give him that opportunity. And Dr. Breakey mentioned great points about protein. That's something everybody should learn and understand, that you don't need much protein. All of that excess protein is actually promoting cancer cell growth and not really helping you. This false mindset is really hurting patients. And because of the everybody thinking that way, oncology team, surgery team, it's very hard that even if we tell the patient gets confused, gets mixed messages, but they're their primary doctor and they have to follow these things. So that's a problem that comes along with that. But at this point, maybe I would be like, now surgery preferable, chemotherapy, think through what you want to do. If you're doing TACE or SIR spheres, those are very focused versus systemic, although they do have some systemic effect because it eventually goes into your system, but you can get a much smaller dose to a focal area as opposed to complete body chemotherapeutic agent treatment.
Melanie's got her hand up.
This has been so great. My mom, she had colon cancer. She had a collapsed bowel, actually, was what she had, and eventually ended up with colon cancer. But I just want to say it's so refreshing for me to be sitting here with you all these plant-based medical professionals. And I talk to so many people, even that are medical professionals, that are still, I just experience so much pushback from this. And I was looking, it was like the most recent, actually, this was from a couple of months ago, but today's dietitian, healthful grazing, and it's got 2 different kinds of processed meats, 3 kinds of cheeses, 2 kinds of white flour crackers, right? And they're saying, healthful grazing, right? So I'm just, it just is so refreshing for me to be here with you all and to be able to take in the wealth of knowledge you all have. Just makes me feel hopeful. So anyway, that's it. I just wanted to say that. Thank you, everybody. And I agree, Dr. Scheuer, I think that patient is really lucky to have you as their doc. Yeah.
Great. Well, thank you for that, Melanie. We really appreciate it. And I think with that, I think we're going to close. So it's been a long day for everybody who had to go to work. And once again, I'd like to thank Dr. Kim Scheuer, who did the heavy lifting here, both by taking care of this complicated patient and by presenting the patient to us, which is, as we all know, is not necessarily our favorite activity. But you did a great job, Dr. Scheuer. Really appreciate it. And Dr. Mutha, we really appreciate that you joined us as our guest panelist tonight. And we loved hearing your words of wisdom. And we'd love to have you back if that's okay.
Absolutely. It was such an honor to be here, and what a pleasure seeing all of you talking about this. I mean, it's like you feel like I'm a part of this community that I miss around, even in my group, that I have to convince every single day to my partners that what are you recommending? This is wrong. So I wish they had some of your wisdom, and I'm pushing the envelope on my side. But Dr. Scheuer, you're doing excellent job. So grateful for what you do, and I'm so your patient must be he's very lucky to have you for sure. Thank you for presenting all wonderful comments and so much to learn from this wonderful group. Would be happy to be back anytime.
Great, thank you. Yep, and Dr. Breakey, again, thank you for your regular service, and Dr. Graff, thank you for your service, and also congratulations on becoming our new medical director. So we'll see everybody next month. Keep an eye on your email for tonight for the survey, and then for when the next event is. So thank you all, and have a great night. And again, and thank you to Bob Frankie, who's in the background engineering this tonight. You did a great job. See you all.
Thank you, Ted.
Bye.
Ted.
Thank you.
My pleasure. Take care. All right. Bye, everybody.
Thank you, everybody.
Good night.
Thank you.